Hello everyone and welcome to Blood and Hematology YouTube channel. The first video of Lymphoid Neoplasms series is about a general overview of lymphoid neoplasms and definition, classification, and clinical and laboratory features of acute lymphoblastic leukemia. Lymphoid neoplasms include a wide spectrum of syndromes, from disorders that primarily involve the bone marrow and peripheral blood, leukemias, to those that initially present as tumorous masses, lymphomas, primarily involving the lymphoid organs. The neoplastic transformation or cell of origin may involve the common lymphoid progenitor cell, or more differentiated progenitors of the T, B, or natural killer cell lineage. The fifth edition of the World Health Organization classification of lymphoid tumors, based on cytology, immunophenotyping, cytogenetic and molecular genetic abnormalities, applies a hierarchical system for classification. That is, it organizes diseases in order of increasing levels of specification, from category, family, class, entity, type, to subtype. The lymphoid neoplasms are classified into three main categories. Lymphoid neoplasms can be categorized according to the presence or absence of leukemia, as a key feature of a type of disease. A lymphoid leukemia is a neoplasm in which the predominant manifestations are in the blood and bone marrow, whereas the term lymphoma refers to a disease characterized by a neoplastic proliferation of cells of lymphoid origin in organs and tissues such as lymph nodes, spleen, thymus, and skin. Lymphoid neoplasms can also be categorized according to the immaturity of the cell. In some lymphoid neoplasms, the neoplastic cells are lymphoblasts, cells that are cytologically and immunophenotypically immature. If lymphoblasts are present in the bone marrow, with or without overspill into the blood, the condition is designated acute lymphoblastic leukemia. Primary infiltration of other lymphoid organs or tissues by lymphoblasts is designated lymphoblastic lymphoma. In other lymphoid neoplasms, the neoplastic cells are mature, and again a given condition is regarded as leukemia or lymphoma according to the usual manifestations of the disease. However, again there is overlap. The precursor lymphoid neoplasms B lymphoblastic leukemia lymphoma and T lymphoblastic leukemia lymphoma comprise malignancies of lymphoid progenitor cells committed to B-cell and T-cell lineage respectively. These neoplastic lymphoid progenitor cells are referred to as lymphoblasts, and the diseases resulting from their dysregulated proliferation are termed acute lymphoblastic leukemia and lymphoblastic lymphoma. Acute lymphoblastic leukemia is the most common malignancy of childhood and adolescence. It accounts for about 80 to 85% of cases of acute leukemia in children, compared with only about 15 to 20% of cases in adults. Acute lymphoblastic leukemia incidence exhibits a bimodal distribution, with the first peak occurring in childhood between 2 and 5 years of age and the second peak occurring near the age of 50 years. Some cases of acute lymphoblastic leukemia in infancy have their origin in utero. Fewer than 5% of cases have a predisposing cytogenetic or genetic abnormality, such as Down syndrome, Bloom syndrome, or ataxia telangiectasia. Clinical features of ALL at presentation can be related directly to the replacement of normal bone marrow elements by neoplastic cells. ALL develops in the bone marrow and invades the peripheral blood and other extramedullary sites. The infiltration of the hemopoietic parenchyma is often massive at the time of diagnosis and leads to a marked reduction of normal trilineage hemopoiesis. Pallor, weakness, and lassitude attributable to anemia are the most common presenting features, and bleeding in the form of petechial hemorrhage frequently accompanies thrombocytopenia. Bone pain is a common complaint, especially in children, and is related to massive marrow infiltration with leukemic cells. Fever is present in more than one-half of patients, but despite neutropenia, bacterial infection at diagnosis is not common. Tissue infiltration in the form of lymphadenopathy, splenomegaly and hepatomegaly, generally of moderate degree, are present in 50 to 80% of cases. Leukocytosis, neutropenia, anemia, and thrombocytopenia are common in patients with newly diagnosed ALL. The severity reflects the degree of marrow replacement by leukemic lymphoblasts. The leukocyte count at presentation may be increased, decreased, or normal. About 50% of the patients have leukocytosis due to an abundance of circulating leukemic lymphoblasts. Marked leukocytosis has an unfavorable prognostic significance, particularly in children. Approximately 90% of patients have circulating leukemic blast cells at diagnosis. Hyperleukocytosis, more frequent in adults, in T-lineage disease, and in infants under the age of 1 year with conspicuous organomegaly, require an immediate therapeutic intervention because of the high risk of leukostasis. Profound neutropenia is found in 20 to 40% of patients. The finding of leukopenia and neutropenia without circulating blast cells is possible, but less common than in AML. In addition to neutropenia, it is fairly common to recognize eosinophilia, even quite marked eosinophilia, sometimes with moderately dysplastic features such as nuclear hyposegmentation or cytoplasmic hypogranularity. Eosinophilia in ALL is usually a reactive phenomenon, independent of the immunophenotype and induced by the release of specific cytokines by the lymphoblasts. Normocytic normochromic anemia is almost always present and can be severe. Anisocytosis and poikilocytosis are not usually present. In some patients, particularly when there is very severe anemia, there are erythroblasts in the peripheral blood film. The platelet count is usually decreased. In a minority of cases, particularly in the pediatric age range, the platelet count is within normal limits or only slightly reduced. The level of serum lactate dehydrogenase is increased in most patients with ALL and is well correlated with tumor burden. Leukemic infiltration of the kidneys can lead to increased levels of creatinine, urea nitrogen, uric acid, and phosphorus. Bone marrow aspirates in ALL are generally hypercellular and almost always show a marked blastic infiltration, often more than 90%, with a clear reduction in the numbers of normal hemopoietic cells. The cytochemical profile of the lymphoblasts, whatever the morphological or immunological subtype, is uniform. They are negative for the cytochemical reactions identifying myeloblasts, peroxidase, chloroacetate esterase, and Sudan black B, and for fluoride-sensitive alpha-naphthyl acetate esterase. The periodic acid Schiff reaction correlates with the glycogen content and is often positive, with fine or coarse granular positivity or with blocks. The acid phosphatase reaction correlates with the content of lysosomes and is useful for differentiating TALL, characterized by a distinct focal paranuclear positivity in blast cells in more than 90% of cases. Lymphoblasts vary in size but fall into two morphologic types. The most common type seen is a small lymphoblast with scant blue cytoplasm, coarse chromatin, and indistinct nucleoli. The second type of lymphoblast is larger with prominent nucleoli and nuclear membrane irregularities. The table shows morphological criteria that are useful for distinguishing between myeloblasts and lymphoblasts. The FAB classification that was used commonly earlier assigned ALL to three cytological categories: L1, L2, and L3. Around 25 to 30% of adult cases and 85% of childhood cases of ALL are of L1 subtype. In L1 ALL, lymphoblasts are small to medium-sized, with high nucleocytoplasmic ratio, scanty cytoplasm, and mild to moderate basophilia, fairly regular nuclear shape, homogeneous chromatin, and small or inconspicuous nucleus. Around 70% of adult cases and 14% of childhood cases are of FABL2 subtype. The cells are medium to large and pleomorphic, with variable amount of cytoplasm and variable basophilia. The nuclear shape is irregular, clefting, and sometimes with indentation. Usually the large blasts have fine chromatin and nucleoli that are fairly well seen, and the small lymphoblasts have denser chromatin. ALL-L3 is a rare subtype with only 1 to 2% cases. In this type the cells are large and homogeneous with abundant and deeply basophilic cytoplasm, regular, oval or round nuclei, finely stippled and homogeneous chromatin, and prominent nucleoli. The most distinguishing feature is prominent cytoplasmic vacuolation overlying the nucleus. The mature B-cell ALL or L3 type is now classified as Burkitt's lymphoma leukemia. Morphological features of ALL subtypes are summarized in the table. According to the WHO classification, ALL is classified together with lymphoblastic lymphoma as lymphoid precursor neoplasms of the B or T cell type. Classification into subgroups is primarily based on cytogenetic and molecular genetic criteria. Immunophenotyping allows the categorization of ALL into the B or T cell lineage and by degree of differentiation, by using a TDT assay and a panel of monoclonal antibodies for T cell and B cell associated antigens. Immunophenotypic categories of ALL include three main types. B lineage ALL accounts for 75 to 80% of cases, and is defined as 4 differentiation stages: pro-B, common, pre-B, and mature B ALL. The crucial markers are CD19, CD22, and cytoplasmic CD79A. Classification of B precursor ALL by immunophenotype is summarized in the table. Recurrent chromosomal aberrations in adult B-ALL are listed in the table. Common recurrent fusion genes and ploidy groups in B precursor ALL are shown in the tables. T-lineage ALL represents 20 to 25% of adult cases and 15% in childhood ALL cases, and characteristically affects males more often than females. Crucial markers are cytoplasmic CD3 and surface CD7. T-ALL can be classified into pro-T, pre-T, cortical, mature T, and early T-cell precursor ALL subtypes. Pattern of immunophenotypic markers expression in T-ALL subtypes is summarized in the table. T-ALL can be classified into molecular subgroups. Further recurrent balanced chromosomal aberrations and frequent recurrent fusion genes in T-ALL are listed in the tables. The CBC results and diagrammatic representation of the leukocyte differential count of a 12-year-old girl showed leukocytosis, neutropenia, anemia, thrombocytopenia, and 87% atypical lymphocytes suspect to neoplastic cells. The patient peripheral blood film examination showed leukocytosis, atypical lymphocytes, and few smudge cells. Composite image of the patient peripheral blood smear showing homogeneous population of small to medium-sized cells with a high nuclear to cytoplasmic ratio. High-power observation of the patient peripheral blood smear showed blast cells with scanty cytoplasm, fairly regular nuclear shape, fine and homogeneous chromatin and small nucleus. The patient mononuclear cells immunophenotyping was performed to determine the blast population lineage and differentiation stage. Based on the immunophenotypic profile, the patient was diagnosed as cortical T-ALL. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.